what they look like. I always use the analogy. I can sit here and tell you all day you put an alginate on it. If you don't know what an alginate is, it makes it kind of difficult, right? Does anybody here know what an alginate is? No. So we're going to talk today, and I'm just going to show you some dressings and how you select those dressings and why you would choose those dressings as we talk about them. So the easiest way to remember this is IDIPAMOP. That's the mnemonic we use for determining principles of moist wound healing. There's a lot of them out there. There's also DIMES and different ones, but this helps you to remember how to determine what products that you're going to use and what your wound needs. So I'll start by telling you that moist wound healing, as we think of it, using these specialty products more than just gauze dressings, has quite a long history. What happened is in the 1960s, there was a Welsh veterinarian named George Winter who actually injured these pigs. He wrapped them with saran wrap, and what he found is the saran wrap actually healed faster than the gauze. So this whole idea of, oh, it needs air, we need to leave it open, that's really not true. That's not the way wounds heal best. So, and we found that out when we started using these dressings. So in the 1980s, which most of you probably were not born then, we started with things like Opsite and Duoderm. Anybody know what a Duoderm is? Ever seen a Duoderm? Or hydrocola dressing. So those were the first on the market. And then today, after we have actually 50 years at this point of evidence-based literature that supports moist wound healing, and we have literally hundreds upon hundreds of dressings that do different functions made by multiple manufacturers. So we're going to just talk about broad category groups, and I'm going to show you some examples of those. So moist wound healing is the current standard of care. So when you think about this, you want to create a dressing that's going to most mimic your intact skin. So that means you maintain a moist surface, you're protecting it from trauma, and you're protecting it from infection, you're insulating the wound bed. And when I tell you trauma and infection, I don't mean infection just from like antimicrobial or microbes like bacteria, things like that. I also mean from critters that may be, flies, things like that, that can get into your wound. So you do want to make sure you're protecting. Okay, so the first thing you're going to do with IDIPAMOP is you're going to identify and treat any infection. So, we follow the CDC guidelines for signs and symptoms of infection, and the goal is to kill the microorganisms without harming any healthy tissue. And there are dressings that we have that are antimicrobial that are designed to do this. So, and I'm going to, we go through dressings, I'm going to show you those, and they fall into all these broad categories. So they'll fall into that, but they'll have the addition of saying, well, this is an antimicrobial dressing, meaning they'll have a product in them that helps to reduce the bacterial level. So when we think about gauze, we've used that as a standard for, people used it hundreds and hundreds of years. But they actually did a study and found that if you take 64 layers and you stack them up of dry gauze, and they put bacteria at the top, how long do you guys think it took for it to get to the bottom? Less than 30 minutes.
Oh my goodness.
It went from the top to the bottom. And if it was wet, it was almost instantaneous because it was like a sieve that just went straight on. So think about your patients that just, for instance, have animals in their home, walk on these wounds that can get, so you want to make sure that when you're choosing a dressing that you choose cover dressings that protect your wound, and that is not gauze. Gauze is no barrier. Okay, so, and also with gauze, it requires more frequent changes. And then one of the things they found is when you actually change a dressing, like a wet to dry dressing, and you're pulling it out of the wound, like you should. Does everybody know what a wet to dry dressing is? Let me back up and say that. So when we talk about wet to dry, what you do is you take your gauze and you put your moistened saline on it, and you pack it into your wound. We talked about those wounds that had depth. It was slow. The idea is this is going to debris. So you allow that to dry in that wound. And when you go back to see the patient 24 hours later, you as the clinician are supposed to reach in there and rip that out. And if it's stuck, too bad. That's the idea. It's supposed to stick because it's supposed to pull all that tissue out. That's the plan behind it. So what they found is that when you actually do that, it aerosolizes the bacteria. And that's why, as clinicians, when you check our noses, we have all these MRSA, VRE. We carry all this stuff around in our nares because we're picking it up at the hospital. That and Whirlpool. So just think about that when you're changing. You want something that When we talk about these dressings, one of the things that most all of these do is they suspend the drainage within them and suspend the bacteria within them. So there's very little aerosolation or release of that, the bacteria that's there. So clinical signs and symptoms of infection is if you have new slough or new breakdown. The wound's getting worse and you're not sure why. You have a change in your drainage color consistency and it increases. You have poor granulation formation or no granulation formation. You have redness and warmth of the peri-wound. So you should, when you're assessing, you should be palpating to see, does I feel warmth, redness? Do I feel induration? Is it hard? Swelling. Do you have pain and tenderness? Is there a foul odor? Any wound breakdown, elevated blood sugars in your diabetics? That should be a key indicator. When you start seeing that sugar spike, something is wrong. And then they'll have delayed healing or not healing. So here's an example of an infected wound. You all see the drainage coming out, purulent drainage. Can you see the redness around the wound? And if you were able to palpate that, you would feel that it's warm, and it's also indurated. So here's another one. So hopefully you guys can see right around this part. She has almost like an abscess there at the end of that. You see that? It goes on her foot. And just a little FYI tidbit, this lady had this done with no anesthesia. None. She just had a general block because she is diabetic and can't feel. So had no sensation whatsoever. Okay, and so here's another wound that's infected. Y'all agree with that? See the redness? And here's another one. And again, this one is not so much red, but you see that dark tissue, the new formation of that was not there prior. So you'll see it start to break down and, form new necrotic tissue. And then here's another one. This was a hematoma. And so I will just also caution you, because you may see these patients, oftentimes when they have a hematoma and that blood is pooling there under the skin, they're at great risk for infection, and those need to be evacuated pretty quickly because they can cause some muscle damage, and they can also lead to infection like this. Okay, so once we've treated infection, we also want to debride the necrotic tissue because they kind of go hand in hand. When you have necrotic tissue in your wound, that is a breeding ground for bacteria because you cannot kill bacteria off of dead stuff with an antibiotic. Think about it. It's not going anywhere near that. There's nothing circulating it, so while you have that dead tissue, it's a thing for your bacteria to grow on, and so the more you have, the more at risk for infection you become. So this will reduce the bioburden, or the level. When we talk about bioburden, we're talking about the level of bacteria there. So I'll back up to say just for a second, when we talk about infection and things like that, we have a group of patients that are not, do not have acute infection, but they have chronic bioburden. And all wounds have somewhat of a bioburden. That's why we do clean dressing techniques. They're not going to be, completely sterile. When you're looking to see if there's bacteria there, you're going to find something. I mean, it's just going to be what it is. So you have to look at the amount of bacteria there too to see, and you can get a bioburden, which means you have a heavy level of bacteria, but they may not be an acute infection. Does that make sense? And so you'll see that happen, especially if you have a lot of necrotic tissue. And if you debride, that can interrupt the, what makes your wounds chronic and non-healing. So a lot of times we do debridements. So there's a variety of ways that we can do that, and we'll talk about those as we go through in just a second. But you want to avoid debridement of stable eschar, and we talked about what stable eschar is. Everybody remember that? That's that hard black tissue. If it's not draining and it's stable, you want to keep that there as healing. If healing is not expected or that's not the goal for care and in compromised patients, we just don't debride that. So when we talk about these, I'm going to ask you guys, on the first one, would you all debride that? Do you see anything draining from it? No, so we would not. The second one, again, nothing draining from that, right? So we would maintain that. This one, in the corner, we would not. The toe, we would not. And this one, we would not, because nothing's draining. But if you look at these are different. The first one, you have an area of pink tissue. Can y'all see that? That's open. in the corner of that right here. You see that? This right here is completely wet, right? We wouldn't have to debride that. This is starting to break down, but generally we would not debride that. But look at this one. This is what I talked about earlier about tissue rings. You see you have hard eschar here, but look at this ring. You have a ring of yellow and then a ring of pink. You will see that on heels a lot. And we have to debride those once you start to get those rings. Those aren't stable anymore. This is a toe. This one is stable. Look at this one. Is that stable? Again, you have that pink ring. Nope. And this one. Nothing draining from it, so that is stable and we would not debride. Does that make sense? And that could be one of the questions on your board, because I see that question a lot. It's like, when do you debride and when do you not? Because it's a big deal. If you get it wrong, that patient can lose a leg. So we just try, if we can maintain it and they're compromised, we don't do it. Okay, so how do we debride? We take patients into surgery. That's just done by a surgeon. I don't expect any of you to, when you finish your program, you're going to be surgeons, so you're not going to be doing surgical debridement, right? I don't do surgical debridement. I'm not a surgeon. But sometimes they can be, your wounds can be so significant that you do have to get rid of that necrotic tissue, and it has to be done quickly. Or you have to evacuate a hematoma like I was talking about, and the surgeon is the one that has to do that, and you have to send them on and say, okay, we need to debride this pretty rapidly. We also have conservative Sharps wound debridement. So what you may see is PTs that you're working under, they may actually go in and do debridement. And this is where we have, loosened slough that you can actually lift up, cut away, or eschar, you can start to cross hatch, things that you can do to actually debride that, to start debridement of that wound and help that along. That's done at the bedside. You may pre-medicate them orally, or if they're in the hospital, they may get, an injection or an IV medication, but it's done right there at the bedside with the patient completely awake and all of that. When we do conservative Sharps, we do it in wound care clinics, we do it in the homes. Okay, then we do autolytic debridement. This is by far the most common debridement that I do in my practice, is autolytic debridement, which means that I let your body break it down and take care of it. And every dressing that I'm going to show you today supports autolytic debridement. That's one of the things they do, is they support your body's ability to break it down and get rid of that tissue. Then enzymatic debridement, and that's where we use medications, or it's a collagenase. It's also called Santyl. That's what you'll see it called, collagenase Santyl. It's the only one on the market currently. You will see that used to debride as well. The mechanical debridement, that's the wet to dry, and then biological debridements, that's maggot therapy. And we actually do use that, and we'll talk more about that in a minute. So conservative Sharps debridement, you don't do it on infected wounds. You have to be careful of people who bleed, because you can't get into that. And the idea is you only want to, the clinician that's doing it only wants to be able to remove or cut away tissue that's clearly differentiated, meaning I can lift it up and away. You do not cut into the good structure, so you shouldn't see a lot of bleeding and things with this. We're only removing what we can differentiate. So here's an example of Sharps debridement that was done, and it's hard to see in this picture, but if you can see, we started to soften this up. This is hard eschar, and when you actually take forceps and lift, it's fluctuant, meaning I can lift it up and down. I mean, it's just barely hanging there, and so once you can cut it away, you can start to see. Here's another example of a debridement where the slough is, you can start to pull it away with forceps and cut it away. There's another one. Can y'all see how you can almost just like take your Q-tip and go right under that edge and cut that away? Okay, and here's another one where we cut this at the edges away. See those edges? Okay, autolytic debridement, as I said, it uses the body's own immune function, so you have to have a functioning immune system. This is really tricky when you talk about diabetic patients, because if they have hemoglobin A1Cs over 6.5 or elevated blood sugars over 180, they don't have macrophage function, and they don't do a very good job of autolytically debriding. So you have to be really careful with your diabetic patients or any patients that's immunocompromised. It's very cost effective because you're using your dressing as a manner of that. And it's also very selective, meaning that you get no damage to the good tissue on their body. They're not going to lose any tissue with that. Okay, so here's an example. This was, when we started out, it had those tissue rings. You'll see that when you start to hydrate eschar and break it down and soften it, it'll turn yellow like this and start to fall away, and it's breaking down. So here's another one. And if it's adherent like this, where you can see the fluffy, you really can't lift it out. You don't have a lot of choice but to do some other form of debridement, because a conservative sharps doesn't work very well if you can't differentiate tissue levels to pull that away. You know, you don't know what you might be cutting under that. Okay, and so here's another example of autolytic debridement, and this is another one. And so, you know, when we talked about staging, we talked about unstageable and why they were unstageable. Here's a good example. Can you all see in a 2-day span, we had this yellow and we started debriding it. What happened? The bottom fell out of it and there was a huge hole underneath. See that? And we wouldn't have known that. That's why it's unstageable, because you don't know how much damage is underneath. Okay, and so here's more of these. Okay, so enzymatic debridement, again, it's this is more expensive. Sometimes you need it, especially for your diabetic patients. Collagenase Santyl is the primary one that we use. But the one thing I want to say about enzymes is they are delicate. So what you clean with, what you cover with, makes a difference. So if you try to put an antimicrobial over your Santyl, there's a chance you're going to inactivate it. If you use a cleanser with a surfactant, there's a chance you're going to inactivate it. For example, the cleanser that's on the formulary where I work inactivates it by 77%. I don't know about y'all, but if I spend $200 on a tube of medicine, I do not want anything inactivating it, right? It's delicate. It's also, because it's an enzyme, it requires a warm, moist environment. If you dry it out, it's not going to work, okay? So you have to think about reading the back of the directions, and it's going to tell you all those things I just told you on the back of it. Don't mix with, and it's got a list. And it's also going to tell you needs, use a moist cover dressing so that it can stay moist and break down. You'll get your biggest bang for the buck that the patient spit on it if you do that. Okay, so here's an example of one that we used in, or you could use these for. Okay, maggot therapy. So the reason I tell you guys this is because you see this gaining traction, and we use it a lot more than you realize. I don't know if any of you have ever had any patients with that, or if you've ever, in your clinicals. First thing I want to tell you is the maggots that we put on there purposefully are sterile maggots, okay? And the way they do that is the blowfly lays the egg. The egg is then put in the sterile environment so that when the maggot hatches, it's sterile. It's hatched in a sterile environment. But the garden variety Oklahoma maggots that are not sterile are still nothing to panic about. It's going to be okay, okay? So the reason I bring that up to you is because every summer I get at least 3 to 5 calls. They've got maggots and the nurse is in tears. It's okay. It's okay. You know, you're going to see patients walk into the hospital, or if you work home health, you're going to go out and find maggots. I assure you it's going to happen. Don't panic. They're not going to die from them, okay? The maggots, what they do is they only eat the dead tissue. So it's very nice because they disinfect the wound and they actually speed healing. So what they do is, you can see this little picture of maggots, they have these hooks that moves them around in the wound. Their saliva secretes and it breaks down, and then they drink. So they don't really bite you. The squirming you feel is from their body, and that squirming action actually stimulates the wound bed. So, you know, here's an example. They're only going to eat the dead tissue, so they're not going to eat anything live. The key to using maggots is that you don't drown the maggots, because they're secreting that and it's going to get wet in there. So there's mesh dressing specifically that you use for that to seal them in, but at the same time allow the drainage to come through it. And I don't have an example of that, but if you're really interested in it, you can find that online. And I'll tell you all about the maggots. However, I will tell you that conservative maggot therapy works, and this is kind of what it looks like when they're coming off of there. You know, they just get trashed after. Okay, so look at that foot. That's, I mean, big difference, you know, before. What it does is it doesn't create the trauma that a surgery does to create all that inflammation. The maggot keeps that inflammation down, and it eats away the dead tissue, and it cleans it, and it's incredibly selective. Whereas if a surgeon's going to do this, they're going to have to cut off more tissue that's live tissue. The maggot's never going to do that. It's only going to go to the dead tissue. So it's very helpful to prepare them for grafts or whatever to heal. So other mechanical debridements, and I don't know if you guys see this in a facility. There's a product called Pulse Lavage. We don't do this at home, and it's kind of lost favor in the hospital because what it is it's a gun, and you're holding it. I've done it one time in my whole life, and I was like, I never want to do that again. You will pulse water into this to the wound, and then it will suck back out. And so you'll have hunks of tissue going through your tubing. But the problem that I have with it is it aerosolizes and there's droplets going everywhere. On me, on everything in the room. And so, that, you know, a wound that's infected, that's really hard to keep a sterile environment when you're shooting water straight at it. And I'm talking about at a pulse, like you're cleaning your car. Big pulses of water. So it's, the PSI is pretty strong to actually get rid of that. What they've actually found is the ultrasound that you see over here in this picture does really quite well. It's small and it takes some bigger time, especially in a larger type wound, but you have a lot more control and we don't have the infection control risk. Whirlpools. I know that hospitals still do whirlpools. I totally get it. But I'm just going to ask y'all, when you walk in that room, you immediately feel the moisture touching your skin. It's swirling and its droplets are going everywhere. What do you think is happening to your skin, hair, eyes, everything that you touch? So it's just an infection control risk nightmare. And so, you know, I don't typically recommend that. Okay, so I want to talk about this for just a second. So we talked about debridement. Can you all see this is a good example of where this is separating? You see that? That's why we would have to debride, because it's separating at the edges and it shows very clearly in that picture. This one as well. Okay, you want to insulate your wound bed. You know, we're still dipping the mop. Cellular functions are going to affect are affected by temperature. So the studies show that when we do wet to dry dressings, one of the reasons it slows healing is not just that we're ripping out the tissue, but every time we reduce the wound bed's tissue, it takes anywhere on the neighborhood of 6 to 8 hours to return to temperature where cellular functions like replication of your cells is actually happening. So if you're changing something 3 times a day, you're getting almost no healing by your cellular functions, right? Or twice a day. You want to leave that as long as you can. So typically, in my setting, the most common dressing change frequency that we have, not that you don't have to sometimes change them daily to get infection under control, because we do that frequently. You know, the goal is not actually to have cellular function as far as healing, but the goal is to reduce the bacterial bioburden and necrotic tissue from the wound. If that's the case, we may change it more frequently. But the most common frequency that we have is 2 to 3 times a weekly. We try not, especially if we have a clean granulating wound, you should not be changing that every day. You should not need to. And it just slows down the healing mitosis that's happening. It reduces oxygenation and all of those things. Again, remember that gauze is not a sufficient cover dressing, and we try not to use that because it doesn't insulate your wound properly, or protect it for that matter. So that goes back to protecting the wound, and you see my stat about the 64 layers of dry gauze. Okay, so next you want to absorb the exudate. So you're going to see on these 2 slides, we talk about absorbing exudate. There's another slide here. They're maintaining moist wound surface. So if you look at these wounds, these are wounds that are all too wet. Y'all see that? That whiteness around that is called maceration, if you remember from when we talked before. That means that they're too wet. Sometimes the wetness can be resolved by dressing, and so that's why I included this picture. You all see that this dressing that we have is what's called a thin film dressing. You may know it as SureSight, OpSite, Tegaderm. Those are some brand names of that. But what it is just a thin film, almost like saran wrap, that goes over that wound. When you put it there, it absorbs 0. 0. There's nothing absorbent about that. So if you have a wound that's wet, it's going to stay wet. So if you change this out and put an absorbent dressing on it, what you'll find is that you'll get better control and that wound will start to heal. So that's why when we talk about moisture, and this is the single biggest thing, if you take nothing away from anything else I said today, moisture balance in your wound is absolutely key. It's a Goldilocks and 3 bears situation. You can't have it too wet and you can't have it too dry. You have got to find just right to make that wound go. As that wound moves through the phases of healing, just right is going to change. So in other words, if I'm in an inflammatory phase and I'm swollen post-op and all this and my wound is dehisced, it's infected, it's going to drain a lot. I move it through that, get the antibiotic, treat all that. you're going to notice that your drainage is going to slow. So while you're using a super absorbent dressing over here, you may not need it here. So you have to be monitoring every time you look at that wound for just right. Is it too wet? Is it too dry? Okay, and then you have to have open wound edges. And when we talk about open wound edges, that means that your edges don't roll. So why does that happen? When you have a wound that has undermining or tunneling, which we talked about, there's no structure underneath it. So it can fall. And then the wounds tend to want to just kind of hem under and roll like this. When that skin grows back and touches itself, it sends a signal to your brain that says, I'm done. And you will not get any more healing from that point on. So you have to keep your edges rolled, and by doing that, that means that you also have to keep your dead spaces in your wound filled. So we'll talk more about that in just a second, but here's an example of a rolled wound edge. Can y'all see that? Looks like somebody just took the edges and hemmed it under. That's a good example. Can you see that's skin all the way up? And I mean, people will actually, I had this patient once that formed just almost like a kangaroo pocket. You could stick your pin light under there, and you could see it just kind of flapped under. And he had skin that went 4 centimeters back, rolled completely under, you know. So you have to make sure you keep that open. And then this edge, can you all see that that's rolled there around the hardware? Which there's a lot of problems beyond the rolling that's going on with that. But here's an example. You see there's not, you can't even see the wound edge there with that one. And here, you see how it's thick and it just looks like the skin rolls and goes right into the wound. You don't want that. You need them open. So how do you do that? You fill the dead spaces and you clean the edges of the wound with your 4x4 and make sure that the edges are staying open. Okay, then next you want to pack or fill the dead space. You do not want to, we use the word pack, but I just want you all to be careful. You do not want to overfill. We don't just jam pack it. It's a fill is what you want to do. You want to just fill it without just cramming it in there, okay? Because you can stretch it, and when you stretch the wound, you're going to avoid it closing like it should. You just want to fill it. And so when we talk about wounds, you know, full thickness wounds will granulate, which means they fill with tissue. They'll also contract. They'll bring themselves in before they epithelialize. So those 3 actions are all happening. It's not just one alone. So here's the loosely fill. And you see we have an example of packing. And again, this is dead space. When we talk about dead space, you have to fill that. You can't just leave it open. Okay, so now we're going to talk about products by group. And I'm going to kind of, I think the best way to do this, I'm just going to go through these and then I'm going to show you examples. Yes, maybe. So, hydrocolloids is the first one. Okay. So these are the main product groups we're going to talk about. Hydrocolloids, foams, thin films, alginates, composites, and hydrogels, antimicrobials. These products are going to be by far the most common products that you will see in any facility. Okay? So we're going to talk about each one of them and show you what they do so that you have an idea. Now, when I tell you there's thousands of wound care products, what I want you to understand is we talk about a hydrocolloid. There's 20 different kind of hydrocolloids on the market. Okay, 20 different people have made those. And then it's also with the hydrocolloid, they have become like tissue and Kleenex kind of situation with Duoderm. Everybody says, oh, that's a Duoderm. Duoderm is actually a brand name by Comatec for a hydrocolloid. The product is a hydrocolloid. So when you hear people say Duoderm, it does, and you go in there looking for Duoderm, you might not find Duoderm. You may find whatever brand they have. So I'm going to show you an example of Exuderm, which is what I happen to have today. It's the same thing, and if I took all these out of their packages from all these manufacturers, they may have some varying differences, but they look largely the same. So what this is a pectin-based product, and I'm going to pull this back and I'll pass this around so y'all can feel it. It sets up maximum adhesion at 24 hours. So this is supposed to stay on 3 to 7 days. It will pull off your skin. If you let it sit there for 24 hours and then you try to take it off, it will pull off your skin. It's key when you remove it that you do what's called a taffy pull technique. So all hydrocolloids. So instead of lifting up and away, you're going to pull like this. and get it to release, okay? Because if you don't, you're going to take somebody's skin with you, okay? If your wound is too wet, this will become white and it will lift off. This is not a super absorbent wound. It can be used as what we call primary dressings or secondary dressings. What do I mean by that? If you have a shallow wound, which we're going to talk more about breaking these down in a minute, but if you have a shallow wound, you can put only this dressing on, or if you have a wound that you need to fill, you can fill it and then cover with this dressing. So it can serve as two purposes, and I'll let you. You'll notice that the edges on this one are nice and tapered. That's supposed to help from lifting up. Most commonly, I will tell you guys, when y'all are out there, one of the reasons that people hate Duoderma hydrocolloids is because if you have patients that are prone to shear, this is not the right product for them. Because when they scoot, they'll lift that up and it'll just wad up in a ball on their butt that they're sitting on. They'll say, I hate that product. Well, that's why you hate it. So you just have to know who you can use it for and who you can't. And you will learn that if you do wound care where it's appropriate. But just to know that it's a hydrocolloid when you're looking for that. So hydrocolloids also have some configurations. So this is a honey colloid. And it actually ends up being more like a solid gel, but I'll let you look at it and feel. The Manuka honey, you're going to see throughout all of these products, and we'll talk about, I think I have slides, but I can tell you now. Manuka honey comes from an area of New Zealand, and its claim to fame is that it's antimicrobial. It has antiseptic properties. So if you think about the antimicrobial, antiseptic properties from John's honey down the street, it might be a 3 to 5 on the Manuka scale. Manuka honey is 97 on that scale, okay? Those plants make all the difference in this. This honey is sterilized, gamma irradiated, so that they make sure that it's quality and then it's tested for effectiveness. So it's a medical grade honey. So when you look at that. So, you know, our little days, I have convinced a lot of doctors, let's leave the betadine and sugar alone and let's use honey. Let's use our honey products because it gives you the same benefit. Why was doctors using sugar with the betadine? And it's because the sugar is a humectant and it pulls. The honey does the same thing. So it almost acts like a peroxide, and you will see white on your wound when you're pulling it off because it has that same chemical reaction that peroxide does. Okay, so foams. Literally, this is the biggest category of dressing on the market is people with different foams. And so I describe these because people ask me all the time. So when it comes to foam, I'll admit I'm a bit of a snob. There's this product called Mepilex, and that is the Cadillac of foams. If you ever get that, it's the best ever. And sometimes when you're taking care of patients, you need a Cadillac. Most of the time, you know, Ford Focus will do the job because it's absorbing and that's all you need. But I'll just tell you that some are better than others. And if you get a chance to use Mepilex, it's the best in the world.